Good evening. This is Mark Howard. I'm here with Patrick Wong. Thanks for joining us to talk about the sacroiliac joint. I am an orthopedic surgeon. I am fellowship trained in spinal surgery. I actually have been practicing in town for 30 years, believe it or not, having come in 1991. And I'll let Patrick give you his bio.
Hi, I'm Patrick Wong. I am a physical medicine and rehab doctor, and I've been here in this area for about 11 years with this practice, Monterey Spine and Joints. I typically will treat sacroiliac problems, not with surgery because I'm not a surgeon, but I'll prescribe things like medications, physical therapy, and then I'll do some injections.
So let's get started. We're talking about low back pain, which obviously is very prevalent. This is an overview of the talk that we're going to deliver tonight. We're going to talk a little bit about the anatomy of the spine and especially the sacroiliac joint, the prevalence of dysfunction or pain that comes from that joint, which can cause back pain, the diagnosis steps that we take, some of the causes and the symptoms, and then we'll talk about treatment. And Dr. Wong will center on what he does for treatment for patients, which is in some of the slides, you'll see they reference to non-surgical management. And that includes a variety of different interventions, belts, injections, et cetera. And then I'll concentrate more on the surgical options, which patients would have if all other treatment options fail and they have persisting high levels of pain or relative disability. So the incidence of and the impact of lower back pain is phenomenal. It's the second most common cause of doctor's visits, only behind the common cold. It's the fifth most common cause of hospital admission. Almost everybody suffers from significant low back pain at some time during their lives. And it can be a significant and disabling problem for up to 20% of the population. As such, therefore, there's a tremendous amount of medical cost and outlay that goes along with taking care of patients with back pain. And fairly recently, that number was estimated in the United States at $86 billion. I'm certain it's higher now because medical costs have just increased. Looking at the spine, basically the spine is the substrate or base upon the rest of the body that supports the rest of the body. There are 24 total vertebrae spanning from skull to pelvis. There's a disc or a cushion between each of the bones. As people in the audience are probably well aware, there's a channel or spinal canal or tube through which the spinal cord travels from the base of the brain down to with nerve roots that exit every level of the spine. And in the cervical spine, those nerve roots exit to go into the upper extremities, arms and hands. And in the lumbar spine, those nerve roots exit to ultimately form the sciatic nerve, which interestingly is a very large nerve about the size of your thumb that lies directly on the SI joint as those nerves traverse from the pelvis into the leg. So you'll see in a diagram we have coming up that the SI joint is intimately and immediately adjacent to the sciatic nerve. It's also a significant joint because it's the articulation essentially of the spine to the pelvis or the upper body to the lower body. So there are tremendous stresses applied to the sacroiliac joint on that basis. Here's a little movie about the SI joint, the anatomy and where it is. Again, the sacrum is the bottom bone of the spine. And you can see it articulates bilaterally with the pelvic bones or the ilium. There's not a lot of motion in that joint, and you'll see momentarily one of the major reasons that there's just a small amount of motion is there's very significant and heavy duty ligaments which support that joint both anteriorly and posteriorly. This is a diagram that shows you those heavy ligaments, how they completely cover and encompass the SI or sacroiliac joint. And it also, in the schematic, shows you the sciatic nerve as it exits the pelvis to travel down the back of the leg. And that nerve is very large, and there are multiple branches, and therefore there's a tremendous amount of nerve innervation to the SI joint and even to these ligaments in the area in the deep pelvis. So SI joint pain is definitely a cause of chronic low back pain. And here are a series of studies. On the left, they're indicating a prevalence or an incidence of anywhere between 15 and 30% may be a predominant or primary cause of low back pain. In the patients in whom I take care of and see, the data on the right suggests that 32 to 43% of patients who complain of sometimes disabling, persisting low back pain after successful lumbar spinal fusion, in many of those cases, that pain is actually coming from the sacroiliac joint. You'll see momentarily that the presentation for SI pain mimics in many cases and is very hard to distinguish from pain which comes from the lumbar spine or pain that comes from the hip joints. And often the pain reporting and the location and the types of pain for pain from the SI joint or from the lumbar spine or from the hip joint, the presentation can be exactly the same. And I think on that basis, especially in the group of patients who've had spinal fusion surgery, it's really been under-recognized as a cause of persisting pain in that patient population, because even those like myself who've been performing spinal surgery for 30 plus years, if you do a big one or multi-level lumbar spinal fusion surgery, it's common for the patients to have some persisting back pain. You hope the back pain is improved from the surgery, and typically what we expect is the back pain to be improved anywhere from 50 to 80% after spinal fusion. But I think in many cases, it's becoming more apparent that in the past, specialists like myself and Dr. Wong, if you will, have missed and not adequately worked up patients for pain that comes from the SI joint. And it's particularly important in patients that we both see, because we both see a lot of patients who've had spinal fusion surgery. So here's probable and potential causes. Interestingly, pregnancy and childbirth can be a fairly common cause, but usually that SI dysfunction or sacroiliac pain is transitory, but that's essentially a function of the pelvis opening up and allowing room for the baby either during pregnancy or during the delivery. It's, as we discussed, very common after lumbar fusion. In any patient who's had lumbar fusion, or any of my patients who may be listening, you know that one of the things we always worry about when we do spinal fusion surgery is what we call adjacent segment disease, or transferring excessive stressors to the next levels or next discs. Well, if somebody has had a fusion at L5S1, which is the bottom level or disc in the back, then the next joint is the sacroiliac joint. So it sort of makes sense that if they've had fusion down to, or that encompasses the bottom level, that you would not be surprised that they're getting what we call junctional stress transfer and adjacent segment disease. Other causes include relatively simple and very common things like falls, lifting injuries, or repetitive injuries. And one of the cases we'll talk about later on tonight is a case of a professional motocross racer. And you can imagine the stresses that a professional motocross racer might experience. So here's a diagram of the typical symptoms that a patient with sacroiliitis might have. And they're exactly like the symptoms they would have from a lumbar disc herniation, or any of the numerous lumbar spinal pathologies that we see commonly and take care of commonly, like a herniated disc, like spinal stenosis, like a degenerative spondylolisthesis. And interestingly, they even sometimes can have pain in the anterior hip and groin area. And that is very commonly seen in patients who had hip arthritis or pain coming from their hip joints. So there's a real crossover. And in fact, the symptom location and presentation on these patients can be exactly like those of patients that have lumbar spine problems with a disc or spinal stenosis, or maybe some deformity, or maybe some instability, or they have arthritis in the hip joint, which also is very commonly seen. Those conditions also can cause things like radiating pain, which you see in the diagram, numbness, tingling or weakness, and or feeling of leg instability, like buckling or giving way, which commonly can be an end stage symptom of advanced arthritis in the hip joint. Similarly, it causes very similar dysfunction or alteration in function to those other conditions that I mentioned, like problems in the lumbar spine, hip arthritis, and not uncommonly, patients may have a combination of these different conditions. And that's why oftentimes the diagnosis of sacroiliitis is rather hard to come to, because you have to rule out or evaluate the lumbar spine and hips, because they cause a very similar set of symptoms. One thing that's kind of interesting with sacroiliitis is that it can cause sleep disturbance, because patients have trouble sleeping on the painful side. You can see this patient who's having to sit, relieving the pressure on one side. They can't sit sort of normally, and that can be problematic for prolonged sitting activities like working in an office or traveling in a vehicle. And they also have what we call transitional pain, which is pain when you're changing positions, like getting in and out of bed, up and down from a chair. And also they can have difficulty up and down stairs. So how do we diagnose it? Well, again, based on what I've said previously, I think historically it's been underdiagnosed and unrecognized in many cases. It's due to kind of information like we're presenting tonight, and frankly, experience by doctors like myself and Dr. Wong, that we're kind of rediscovering or having a better appreciation of sacroiliitis or SI dysfunction. Historically, doctors had not been trained to even think about it or diagnose it. And because other very common pathologies cause the exact same set of symptoms, like we've talked about lumbar spine or hip, that commonly is just not even considered. In the past, I think all those things have led to patients undergoing unnecessary, usually lumbar surgery, because the doctor wasn't even thinking about the sacroiliac joint, rather only the lumbar spine and whatever they were operated on in that part of the body. So to make a definitive diagnosis, these are the three things that we sort of hang our hat on. One is the patients usually can one finger point to exactly where the pain is. And as you can see this diagram, that's not at all conclusive, because that's also the exact same location that anybody who has low back pain from any source typically would point to. We have some provocative tests, and we'll go through those here in a future slide, but mainly they have to do with compressing, distracting, or spreading, or if you will, torquing the joint to cause a reproduction of the pain. But diagnostic criteria and option number 3 is really the gold standard. If you're strongly suspicious and you want to make a definitive diagnosis, and also, frankly, for treatment, and Dr. Wong will speak about this, is the SI block, the sacroiliac injection. So again, option diagnostic criteria number 1 involves localizing the pain. This patient is pointing to a very common location. There's a dimple that we all have on our lower backs, which is called the posterior superior iliac spine. Very commonly, the pain is referred to exactly that location. And as this schematic or slide shows, if the pain is below L5, which is the bottom mobile vertebra, consider the SI joint. And if it's above L5, consider other conditions like lumbar spine conditions. One way you can localize L5 is put your fingers on the top of your pelvis bone. That's called the iliac crest. And typically that location is exactly in line with the L4-5 disc. So if the pain is above that, chances are it's probably coming from the lumbar spine. If it's definitely below that level, you can't rule out the SI joint. Here's a diagram and some of the different tests, but essentially they all involve compressing, distracting, or in some way torquing or straining the SI joint. Now, several of these, you also reproduce strain at the hip joints, so they also can be positive in cases where the patient has significant hip arthritis, especially, for example, the thigh thrust, number 2, the Faber, number 3, which stands for flexion, abduction, and external rotation, or the Genslin's maneuver, which is, as you can see, kind of a rotational. You're flexing the joint on one side while you extend it on the other. So usually to concretely make the diagnosis from these tests, they recommend that, number 1, you do all of these tests in a slow, gradual, steady fashion. So you try to take away the patient guarding or going into protective muscle spasm. And then ideally, it's very supportive of the diagnosis of sacroiliitis if they have at least 3 out of the 5 of these tests that you consider positive.
Thanks, Dr. Howard. That was a really good intro. Like Dr. Howard mentioned, that because of the fact that the SI joint lies in such an interesting area, lower back pain, hip problems can all kind of similarly mimic the pain that you get from an SI joint. So the ultimate and gold standard way to diagnose whether or not the issue actually is coming from the sacroiliac joint is to do an injection. And one of the easiest ways to start with is to inject just lidocaine. And so this would be called a diagnostic SI joint injection, where using an X-ray machine, you can see the images on the right, we can stick a needle in between the joint space, which is a very, very thin space. And all we do is inject just a small amount of local anesthetic. So 1 or 2 cc's of 1% lidocaine, or 1 or 2 cc's of 0.5% marcaine, with the idea that since lidocaine or marcaine only lasts an hour or two, if you get relief for an hour or two while it's in the joint, that diagnostically proves that the problem, where if your pain goes away for that first hour or two, it proves that the problem is coming from that SI joint. Diagnostic SI joint injections are very, very useful. You could use this number 50% as kind of the marker if you get more than 50% relief after the injection. But a lot of times what we really want to see is whether or not the patient can do some of the things that they couldn't do before after we do the injection. Some things like that are functional, like bending, lifting, and stepping, going up and down stairs. That gives us a lot more information about whether or not the injection actually worked. Besides doing an injection just to diagnose the problem, there are definitely a lot of other medications or medications we can use to try to reduce the pain. And these are the same type of things that you would use for any kind of back pain: anti-inflammatories, muscle relaxants, nerve medications, kind of calm nerve pain down. Those can also be used for the SI joint. We definitely are big believers in physical therapy because there are exercises you can do to help stabilize the pelvis, strengthen some of the hip muscles that can help kind of stabilize the SI joint if you happen to have any sort of trauma and extra motion of that joint. The sacroiliac belt, for some people, can be very helpful, where basically it's just a strap that pushes and compresses the sacroiliac joint so it doesn't move much if we believe that the SI joint is too loose. And then we can do steroid injections and something called radiofrequency ablation, where we can actually burn the nerves away that feel pain from that joint. If you remember, Dr. Howard mentioned all the different nerves that branch off and innervate the ligaments and the actual joint. We can burn some of those nerves so that the body is no longer able to feel pain from those elements in the joint. So here's an SI belt, and essentially what it's doing is it's replicating one of the tests where when we compress the pelvis together, that tightness prevents motion of that joint. And for a lot of people who feel like they have too much motion of the joint and that's what's causing their pain, it actually could feel a lot better. The problem is that most patients don't like to wear this belt all day, 24 hours a day. It moves around a lot, doesn't fit everybody, and so it doesn't quite work for everybody. Not everybody has that pelvic shape like in the picture there. We also believe in physical therapy because there are some certain exercises you can do that will actually realign the pelvis sometimes if we feel the pelvis is too loose. If it's a mechanical issue that's causing the pain, you can work on strengthening muscles that support the joint and restoring any kind of muscle imbalances that are causing too much torque on that joint. A lot of these exercises are very similar to the exercises you would do if you just had regular back pain from your spine as well. But this is always a good way to start. We usually will start with some physical therapy if patients haven't tried it yet. And then finally, if the medications aren't working or the physical therapy is not helping and we still just can't get relief, one of the things we can do is specifically target the actual SI joint with cortisone. And similar to the injection of lidocaine or the anesthetic, we'll use an X-ray machine to guide the needle into the space, into the intra-articular space of the joint, and inject a little bit of contrast under X-ray to see that the medication is flowing into that joint correctly, and then only inject a small amount of steroid because that joint itself doesn't really hold much fluid. It's maybe a millimeter or two wide, and so a little bit of liquid can go a long way in such a small joint. It also helps us diagnose the problem as well, because when we inject cortisone and lidocaine together, if the patient experiences immediate relief after we do the injection, then that gives us a little bit more confidence that the sacroiliac joint was the cause of the pain. And then if the cortisone injection doesn't work, there is a procedure what we can do where we actually will burn away nerves to the joint. It's a little bit more difficult procedure. It's not performed that often because a lot of times the cortisone injection does work. And so it's pretty effective, and it's rare that we ever have to end up doing something called radiofrequency ablation. But there are ways that you can target specific nerves that feel pain from the joint. And the tip of the needle heats up instead of injecting cortisone or lidocaine, and it actually will dissolve or burn away the nerve so that your body won't be able to sense any of the pain from the joint. This isn't a permanent fix because those nerves will grow back over time. It may take 6 months, it may take a year for them to grow back, but the body's natural ability to repair nerves is what allows those nerves to grow back over time. And then patients will notice the pain come back in about 6 months to a year. I'm going to hand it over to Dr. Howard.
So in the unlikely and infrequent scenario where Dr. Wong doesn't get you better with all the techniques that he discussed, we do have a rather slick and ingenious and very minimally invasive surgical approach for patients who just have persisting and long-term functional dysfunction or disability. And that is this system called MIS, minimally invasive surgery, SI joint fusion. You can see essentially what they are is they're little dowels, not of wood, but of specially coated titanium that you thread across the joint. And to get the immobilization, especially the rotational immobilization of the joint that you want, the most appropriate construct for this is placing 3 of the dowels across the joint, as you see in the picture there. This is just a little cartoon. Kind of shows you the process. There's a picture of the quite heavy ligaments that stabilize the joint front and back. Shows you some of the mobility from that joint. And this shows a delivery, a percutaneous delivery, meaning through a very small incision of the 3 implants traversing the point, which give you immobility. And as you'll see from the other materials, that you get, it's specially coated. The implants are triangular in shape, so there's no rotational deformation or abnormal rotation, and they're hollow in the middle. So literally the bone, because you're fusing the joint, the bone both grows into and onto the surface of these implants, and then it grows through the middle of the implant. So you get a very exuberant amount of bridging bone. And that's the key to getting immobilization of the joint and successfully treating the pain from the joint. Couple of cases just to demonstrate. Here's actually one of our local cases from Monterey Spine and Joint. This gentleman had multiple lumbar spinal fusion surgeries, but essentially ended up having a solid fusion at the bottom 4 levels of his lumbar spine, that is L2 through S1. He had kind of increasing low back pain and difficulty with certain activities, especially activities involving changing positions, sit to stand, bed to sit, etc. He had positive provocative tests. He had 2 temporarily successful SI injections, and he had pretty classic sciatica-type symptoms, though his spinal imaging did not reveal any either disc bulge or bone spur that would be causing that kind of pain to radiate down the leg. So these are x-rays, and you can see all the hardware in his lumbar spine from his prior fusion surgeries. 5 screws are visible in that picture, but you can also see the 3 SI bone or iFuse implants for the sacroiliac joint. Here's another case. This is a younger person, 48 years old. She had prior 2-level lumbar fusion at L4-5 and L5-S1. She had some positive provocative testing, the thigh thrust and the distraction signs, and pretty much had the complaint that she really wasn't able to stay in any one position, stand, sit, etc., for any prolonged period of time, and constantly had to change positions. Here's a CAT scan, and this case is kind of interesting because on the left-hand picture, you can see she actually has pretty significant bony changes on either side of the sacroiliac joint, sclerosis or increased density in the bone. And that's not commonly seen, but in pretty much any joint in the body, it can be a telltale sign that that joint has some significant, what we call arthropathy or joint problem, and can be producing pain. On the x-ray on the right, you see evidence of her fusion hardware where she had been fused previously at L4-5 and L5-S1. So she had successful injections of the SI joint. In fact, she had a series of them over a 3-year period of time, but the pain kept recurring. And so she ultimately opted for the SI fusion procedure and ended up having it done on both sides about 2 months apart. And here are her x-rays. A lot of that metal or material that you see in the right sided x-ray, that's actually a temporary guidance tool that we use during surgery that allows us to do a real-time CAT scan of the patient's spine or pelvis on the operating table, and then utilize that CAT scan data to precisely guide the surgeon on the placement of any tools, Steinman pins or metal pins, drills, burrs, etc. So that's the newer technique that we now utilize commonly, placing all hardware, but including placing this hardware for the SI fuse procedure. Third case, and this is the gentleman I referred to previously. He had a history that he was a competitive motocross racer and rider for many years early in life, had chronic pain. It localized to the sacroiliac joint. And he had, most importantly, had 85% pain relief with his injections. He had what I would consider to be normal x-rays. They don't really show much here, but notably at age 40, you'd expect, and these x-rays confirm that he has quite normal appearing hip joints. There's no evidence of any significant hip arthritis here. So again, he had the SI fuse procedure. Again, you see the three on the left-hand picture, the three fusion dowels on the right side of that picture, and the other apparatus is that guidance, that temporary guidance tool that we use when we do three-dimensional navigation or guidance during surgery to place these in a very safe and precise manner. And again, here's a plain x-ray would show what we achieve with that unilateral SI fusion procedure. So here's some of the data and some of the outcomes. There's been a lot of literature produced. Somewhat surprisingly to me, as of October 2019, over 55,000 of these types of surgeries have been performed in the world. And in the lower left, essentially that's a pain scale, if you will. So the higher those lines are, the greater the pain the patient has. And you can see how with this type of surgery, patients had significant and almost immediate pain relief, and then it was sustained, such that overall, and I think it's a total of 10 or more studies there, one of the common questions that patients are asked of, for the same outcome, would you undergo the same procedure? And in this case, 91% of patients were satisfied and said, yes, I would definitely do this again for the same outcome. Similarly, this is the pain scale. Pain reporting is the left-hand graph, and the Oswestry Disability Index is the right-hand graph. And essentially on the left-hand graph, if you have an improvement of 20 points, is significant. On the right-hand, if you had an improvement of 15 points, it's considered significant. So you can see that in both cases. Now, this study was kind of interesting, this 2-year data, that NSM is non-surgical management. And the great majority of patients between months 6 and 12 actually chose to switch over and have the surgery. And you see the dotted line then kind of matching the iFuse or the surgical patient population. And that was interesting because my recollection from that study is 80% or more of the patients crossed over, said, this isn't working, I'm going to have the procedure, with the desired outcome of decreased pain and increased function. And so here's some 5-year data. And the encouraging thing here is that the improvements in pain and in function persist and remain unchanged out through 5 years, which is very meaningful. So in summary, if you have back pain, you ought to know. And since you now know, you probably ought to mention your physician or ask them whether or not they've given any consideration to pain coming from the SI joint. And that's particularly true if you've had previous lumbar spinal fusion surgery, especially if you've had it at the bottom level of the spine, which is L5S1. As we discussed, if the SI joint is known to be or suspected to be a source of pain, there are multiple treatment options available to you. Ultimately, there is a very successful fusion option, which thankfully is not performed very often, because majority of patients get better with all the other techniques that we've discussed: therapy, activity modification, medications, and in many cases, injections, corticosteroids specifically. So if you suspect that you have this condition, or you would want to be further evaluated or considered in that regard, both myself and Dr. Wong would be happy to have you come in to see us at Monterey Spine and Joint. And here is a reference, and if you can refer to the back pain webinar as your referral source, then we'll have a baseline from which to start. With that, I think we're willing to open the floor up to questions.
So if anybody has any questions, I think there's a Q&A box that you can type them into. If you see that on your screen, and then I'll read out the question, and we both can answer the question if you guys have any. So far, I don't see any. I wonder if people are able to actually see the Q&A box. I think there's also a chat box you can press on too, that if you have any questions, you can put your question in the chat box. No open questions so far. Oh, here we go. So there's one. So the patient's asking, hello, will MRI show SI joint problems? I'm assuming what you're asking. And what do you think, Mark, about MRIs and imaging?
Yeah, commonly MRI does not show a clear-cut pain generation from the SI joint, unless the SI pain is a function of some sort of inflammatory or some other type of arthropathy, meaning joint problem, or something along the rheumatoid arthritis, or things like rheumatoid, lupus, ankylosing spondylitis, psoriatic arthritis, things of that nature. Things that, for example, many patients will see a rheumatologist for. Those are called the inflammatory or rheumatologic arthritides, and that may very well show up on MRI. But commonly, because painful SI joints either emanate from either hypermobility, which is abnormal and excess motion at the joint, or just continuous strain, MRI is not a very useful diagnostic tool in many cases.
Yeah, I would agree with that. I don't see a lot of sacroiliac joint findings on MRI. A lot of times the radiologist will just notice that it's normal. The other question is, what is the best way to avoid this problem? Do you want to take that?
Well, the best way, and it's also by far the best way to take care of lumbar spinal pain problems, that is kind of a lifelong or at least frequent and continuous rehab and strengthening program, where you're strengthening your core muscles. And by that, I mean doing a regular routine to stretch and strengthen your abdominal muscles. And those exercises also get the deep pelvic muscles, like your hip flexors, your psoas, etc. It involves working on the back muscles, the extenders, the gluteals, the gluteus maximus and medius. Those are trying to keep those muscles strong. Is really the key to treating both lumbar spine and this particular problem. So far and away, that's the best conservative and rehab approach.
Somebody else asked, can you take Mobic for long term if it helps? 7.5 milligrams. Do you prescribe a lot of Mobic? I use a lot of Mobic. I think it works pretty well for most people.
I don't, but my opinion is that Mobic is in the same category as many other, NSAIDs, non-steroidal anti-inflammatory drugs. And as long as you don't have any known liver or kidney dysfunction, and or your primary care physician checks on that every year or two, I think you can take it for years. I have historically prescribed just ibuprofen, also called Advil, or Aleve, which is also called naproxen. But as long as you don't have any liver or kidney dysfunction, we have patients that take those types of medicines for decades. A series of chat questions on my screen. Do you have those
I don't have.
on the right?
I don't. I have Q&A questions. I just have 3 Q&A questions, but if you want to take on any of the chat ones, you can. So on your screen, you see it on the right. Yeah, if you want to pick 1 or 2, we can answer them. Is your cursor coming up? Huh. It's moving it on mine. Mm-hmm.
I've got a chat question. This question is, my question is, with degenerative disc disease, can I have SI? And the answer is certainly yes. As I discussed previously in the talk, it's not uncommon actually to have all 3 conditions, which is lumbar disc disease, some element of pain coming from the SI joint, and some element of pain coming from your hip joint. And that's why in many cases it's difficult to ferret that out, what pain is coming from where, because many of the treatments are the same, but obviously, especially the invasive treatments can be markedly different for the different areas. I have another question in the chat line. Have you had success getting insurance to cover the different treatment options, parentheses, specifically ablation? And I'll hand that one to Dr. Wong.
A lot of it depends on your insurance, unfortunately. They typically have the final say. A lot of times they require patients to have gone through all the other forms of treatments first, like medications, physical therapy, and the injections, and shown that none of those worked or they were very mildly successful. Then they'll authorize the radiofrequency ablation. But in my experience, we don't do a lot of that because most of the things like physical therapy and medications and injections do work. So for the majority of the time, for majority of my patients, we don't end up having to do the radiofrequency. Somebody asked in the chat, if you have normal alignment, will a chiro help? I can't really speak to that because I'm not exactly sure how chiropractors approach the sacroiliac joint and their philosophy behind it. But what do you think, Mark?
Yeah, essentially, there's only a couple specific conditions or diagnoses for which I recommend against manipulation. And that can be, of course, by a chiropractor or an osteopath or some physical therapist. And that's in a situation where I know somebody has a significant herniated disc. I'm not opposed to somebody trialing manipulation for this condition. And I'm sure many people do. And as we know, manipulation in chiropractic has proven to be beneficial for many people. So I suspect that pretty much anybody who ever gets to the point that they're having a discussion with me about an SI fuse procedure, they almost in all cases have tried chiropractic and manipulation, because that's kind of true for all these conditions that we've mentioned tonight. I've got a couple others on the chat, dude.
Go for it.
I've got another chat. Does weight have any bearing on the long-term benefits of any of the procedures? And kind of the short answer is yes, I think it does. I think the more weight you're carrying, and if you have a painful or a degenerative or a hypermobile joint, whether it's SI joint or any joint for that matter, arthritic, the more forces that are being applied to that abnormal and painful joint, the more problems you may have because of the weight. So to the extent that somebody can lose weight and unload some of those forces that are causing pain, I think in general, that's always a positive and a good thing to try to do. On the other hand, both for this condition, sacroiliitis, but in general for the lumbar spine, even much more important from my standpoint is somebody who's invested in and diligent on a good core strengthening program. And you can be very diligent and do a very good job of that, even if you're overweight. So short answer is excessive weight on a painful joint is not good, but even more importantly is diligence on a rehab and strengthening program. I've got another question in the chat. Does osteoporosis preclude this procedure? Short answer is no, unless it's severe. And if you're worried about it, then I'd certainly check a bone density test. If somebody had drastic osteoporosis via bone density testing, I would counsel them to treat that medically with one of the numerous bone building medications that are out there and available to us. Because obviously when we do the SI fuse procedure, we're putting in the metallic implant, and normal bone withstands that very well. And even I wouldn't be too worried about osteopenia, but I would have concerns about pretty advanced osteoporosis, which I would treat vigorously medically so you can increase your bone density pre-procedure. I've got another question on the chat. I have degenerative disc disease. After watching this webinar, I believe I can have SI. My pain is intense. I take pain medication in the morning and at night. Sometimes I'm not able to sleep. Again, I think you're absolutely right. I think it's possible to certainly have degenerative disc and SI pain. But now, hopefully, after tonight's webinar, you've got some clues about maybe some different approaches, or at least some diagnostic things that you can even try on your own that may help you try to differentiate. And if the pain is intense as you're reporting, you probably need to come in and have an evaluation by myself or Dr. Wong, because it sounds like on that basis, you may very well be a candidate for an SI block or injection type procedure both for diagnosis and for treatment.
No more questions. I'm good. Let's just wrap this up, I guess. Thank you everyone for attending our live webinar, and thank you for your questions. If you do have any more detailed concerns and you would like to make an appointment with us, again, feel free to call this number or text this number and reference back pain webinar, and somebody will get back to you and set up an appointment. All right.
Have a good evening.
Have a good evening.